Okay, so we have a lot to cover in the next 15 minutes. We need to discuss how MRI can affect the entire pathway from suspected cancer to death. So this will just be a run-through of the clinical needs in this disease. Now, if we think about patients who have cancer, we can broadly divide these patients into those with localized disease and those with advanced disease. And within these groups, you know, there are certain cancer states, and I've just outlined them here. The important thing to remember is that the disease frequency decreases as you go from left to right because you hopefully cure patients. But as you move to the right, mutational tumor heterogeneity increases, and that makes different challenges as patients progress in their cancer journeys. Now, if we take the very mildest form of cancer, which is the low-risk cancer, we know that there is a pathological state of very low risk and low risk. But within this group, there are a number of challenges. So on the left-hand side, I put down the problems of categorization. So one of the problems of categorization is that about 30 to 50% of patients are misclassified. Another problem with the categorization is that about 30 to 50% of these patients get active treatment in the first 5 years, whereas the mortality of these patients is probably about 3% over 10 to 15 years. So you can see that this is a challenge. So clearly, this points to a clinical need. And the clinical need is to improve risk stratification. In other words, identify those patients who are high risk but have been misclassified into the low risk category. And the other way is because half of these people are getting treatment, you're over-treating a lot of patients. So we want to minimize over-treatment and therefore treatment-related harm. But the role of imaging, therefore, is to confirm that there is truly low-risk disease present so that we can allow active surveillance to take place and therefore to stop over-treatment. If you're going to do treatment and the patient opts for this, then we want to make sure that we perform surgery which is minimally invasive and nerve sparing. So these are some of the clinical needs in this particular group. And clearly there are contributions that imaging can make. And in this particular instance, we're going to talk about MRI. Now, if you look at this paper that was published a few years ago, it definitely defines that as patients go from left to right, that MRI is one of the new tools that helps in the risk assessment, so helps for the selection of active surveillance, but also in the monitoring process. And finally, MRI helps you look at those patients who need definitive therapy. And this was recognized by the PRECISE group. So the PRECISE group has just published this paper in 2016 where it recommends doing MRI in patients with low-risk disease to, one, identify those high-risk patients who are misclassified, but also recommends the use of MRI to promote the monitoring of these patients to see what changes. And by looking at what changes using imaging and classifying the changes, you can therefore come up to a recommendation for a management depending on what's seen. So for example, if an MRI shows a stable appearance or a diffuse process that's consistent with cancer that's not changing, then you can continue active surveillance unless other adverse features appear or other biomarkers change. So let me just show you a patient in 2008. Okay, so here's a patient with low-risk disease. There is non-specific low-signal change in the peripheral zone of the prostate gland bilaterally. This tumor here anteriorly on this diffusion sequence was never sampled because a truss biopsy just doesn't go far enough anteriorly. So this patient is potentially misclassified. Okay, but this patient on conventional measures would go for active surveillance. So we see him in a year later, and can you see that anterior lesion here has grown? Okay, so this is using MRI as a method of monitoring with the conventional way of doing it and saying that lesion has changed. That lesion has changed, that was targeted. That was an intermediate risk prostate cancer, and that patient then went a focal ablation of that lesion. So you can see how MRI was used in apparently low-risk disease. A year later, the patient was reclassified as intermediate risk and then goes on to treatment. So you can see how MRI can be useful to promote therapy. So while we're talking about intermediate risk categories, you need to realize that within the intermediate risk categories, there's a huge misclassification. This is if there's any misclassification going on, it's intermediate risk. And people have recognized this for some time, and we're now dividing intermediate risk categories into a favorable and an unfavorable category. So if you were to look at this patient here, on the left-hand side, this is the one I showed you previously. This, we now know, is an intermediate risk prostate cancer. This was Gleason 3+4 on a target biopsy. But this large tumor here is also intermediate risk. Now, clearly, the prognosis is very different. One, you got a big mass sitting in the right side of the gland, highly cellular. This is Gleason 4+3, intermediate risk nevertheless. The guy on the left-hand side is also intermediate risk, but has a small amount of Gleason 3+4 cancer. Okay? So you can see how MRI is saying bad, good. Okay? And in fact, you can use MRI to try to prize apart the intermediate risk category. So if you have unfavorable disease, depending on conventional criteria, the role of MRI is staging, with a view to curing the patient if possible. So if it's unfavorable, then the role of MRI is to stage, TNM. Potential for cure, yes, no. Get the surgery, get the external beam radiotherapy, whatever you need to do, dissect the lymph nodes and do adjuvant therapy for as long as is needed, depending on the patient's risk of nodal disease. Now, the interesting thing is this. If the patient looks favorable, the role of MRI is very different. It's not to say TNM. It's saying, is this patient been misclassified? Could this patient be suitable for initial active surveillance? In other words, do I need to act now or can I act later? Okay? And I just wanted to show you an example of that, if I can get to it. So here is a patient who was intermediate risk to start with. So you can see he's got 3+3, so that's low risk, but his PSA is 19.19, right? So that automatically puts him into the intermediate risk category. But you look on his MRI and he's just got a little bit of non-specific stranding in the left peripheral zone. Nothing on the diffusion scan. So we said this patient is suitable for initial active surveillance. We're not saying he is completely suitable, we say, but you could watch him. So look, 2013, 2014, 2016, right? So he missed 1 year, okay? And his PSA is going up. Now look what's happened. Now by definition, he's got high risk on the basis of the PSA alone, right? So no longer suitable for active surveillance, correct? He gets a rebiopsy, 3+4, right? So his grade has gone up, but he is high risk. Why? Because of his PSA. And now he gets high dose rate brachytherapy. So you can see how we used imaging to say, let's just watch this guy, 2013. That scan was done last week. Or was it this week? This week. Okay? So we watched him for 4 years and then said, you are now high risk, definitive therapy. So you can see how MRI is promoting a personalized approach to this person's treatment. So when we talk about high-risk cancer patients, some of these patients are curable. And the MRI is there to say, this guy is potentially curable, do it now. But most of these patients aren't. They have high-risk disease, therefore they have lymph nodes positivity, and they have metastatic disease. So if he's going to be curable, the surgical priority is negative margins. Negative margins. So MRI is there to promote negative margins. But the question is, how good are we at negative margins? The answer is not very good. The answer is not very good. So here's a meta-analysis published recently for looking at extraprostatic disease. The specificity is great. It's 95%. It's great. The sensitivity isn't good. Isn't that great? 60%. So what does that mean? That means if your radiologist is a bog standard radiologist, not a specialist, and he says, you know, I think there's extraprostatic disease, then the chances are that he's right, right? He's not very good, but he thinks, I think there is, then you should believe him because of his high specificity. On the other hand, if he says, you know, I think it's okay, and if he's a regular radiologist, don't believe him. He's going to be wrong 50% of the times. He's going to be wrong, but you may have a brilliant radiologist, right? So in other words, you need to know how good that other guy is, right? And that comes with discussing this type of imaging in a multidisciplinary meeting, which is why we are all here. The other thing here is that we want to find metastatic disease. The problem with metastatic disease is all the guidelines are wrong. Every single one of them. Some of you are writing these guidelines. I would say the majority of them are wrong. And they're wrong because you're still emphasizing old technology. And I'll tell you why in a second. So look at the sensitivity and specificity of next generation imaging versus bone scans for metastatic bone disease. If you look at this ROC analysis, there is no doubt that PET and MRI is way better than bone scans for the detection of metastatic disease. There's just no doubt about it. Because now we are talking about advanced disease. When we talk about advanced disease, we're talking about metastatic, either castrate-naive or castrate-sensitive. Castrate-sensitive or castrate-resistance. Now we know that there have been major impacts of imaging on predicting patient prognosis and management, and I've just laid this out on this slide. We know, for example, that if imaging says the patient has metastatic liver disease, they are going to do badly, right? If imaging says this is bone-only disease, they're going to do intermediate. If imaging says there's lymph node positivity, they're going to do quite well. We can do much better than this and separate these groups out much better by using more modern techniques. So why does this matter? It matters because it matters for treatment prescriptions, right? So for example, if you look at this data that's just come out, if you have low volume disease, castrate-naive prostate cancer, right? ADT alone is as good as adding ADT plus docetaxel. If you have high volume disease, in other words, more than 4 metastases or visceral disease, then you should combine ADT with chemotherapy, right? So you can see how imaging is telling you to go one way or the other in the metastatic setting. And this is the type of advantage that imaging brings. So are these tools that we have, CT and bone scans, fit for purpose? I would say no. Why do we say no? Well, when we say that the patient has M0 disease, they actually have M+ disease, and that's one problem. The other problem is that we can't identify patients who are not benefiting as quick as possible. As a result, we don't switch therapies in time. And this is a real issue. I just thought, I'm over time, but I'm just going to show you one example and then conclude. So here is a whole body MRI scan showing retroperitoneal lymph nodes. After enzalutamide, 24 weeks, we can see there's a new deposit on the MRI scan, but not on the bone scan. the patient's triage is based on bone scans. So if you look at these images, you can see that this is the data of oligometastatic progression. Bone scan shows polymetastatic disease progression 25 weeks later, and that's when the treatment changes. So the MRI showed you progression 24 weeks before the bone scan, and this is a real issue, okay? And so the guidelines, and I've got you the guidelines on this slide, continue to say you should use imaging, number one. Number two, you should use bone scans and CT scans, but the imaging guidelines are now saying use MRI scans. And this is the METRADS guidelines on the bottom row. Okay, we'll just switch to that. So why are we going down this route? We are going down this route because of this. We are interested in high-precision medicine. I hope all of us are interested in high-precision medicine. And that means we're using lots of drugs. At the moment, CT scans and bone scans only emphasize progression, non-progression in bone disease. Use next-generation imaging technologies, PET and MRI, and what you do is you split that group into three. So the bone disease gets split into progression, no progression, what you're doing now, to response, stable, and progression. That's the paradigm shift. It's very simple. 2 categories to 3 categories. And that promotes the precision oncology medicine agenda. So these are my take-home points. I'd be happy to take any questions later on. Thank you very much.